A very warm welcome to all of us who are here this morning on a very, very important day, as it marks 4 years since the declaration of COVID-19 as a pandemic. What started as a public health emergency had far-reaching and snowballing repercussions across sectors and aspects of life. These challenges were compounded. What happened in the last 4 years? Climate change, geopolitical crisis, global economic slowdown, and it has brought about a need for us to focus on building more resilient systems and also institutions. Health is something that's overarching all of these. So, we are here to discuss that this morning. 4 years has passed by. And do you feel in a sense that the world has forgotten and moved on? We have gathered here today to ensure that we do not repeat the mistakes of what we did 100 years ago when Spanish flu happened. We come together to ensure and learn that we have better ways to prevent and manage crises. To facilitate this exchange of reciprocal learning, knowledge co-creation, knowledge sharing, the Global Learning Collaborative for Health Systems Resilience was born, set up by Access Health International as its secretariat, with the active support and the involvement of the Rockefeller Foundation. A year after its launch, we had our first conclave in March of 2022. It was graced by 40+ speakers globally, 150 stakeholders in physical attendance, and more than 400 participants online. This year, a year later, we have as many nations represented. We have built a membership base of more than 100+ people, and we are looking to see how our country chapters, which were launched last year, become more active. This conclave is going to be yet another milestone because the learnings are now becoming more intense, peer-to-peer, and of course, thematic areas that are growing based on the need. Without further ado, I'll call upon Dr. Krishna Reddy, the CEO of Access Health International, to set the context for the conclave. And before that, may I request Dr. Sohel Saikat also to come and join us on the dais. To the audiences that talk about health systems, Dr. Reddy doesn't need an introduction, as does Dr. Sohel Saikat, but I am just going to take a minute to speak about them. Dr. N. Krishna Reddy is a distinguished senior cardiologist and the former CEO of Care Hospitals. Currently spearheads Access Health International as its CEO. With a legacy of leadership in healthcare, he has championed accessibility, affordability, co-founding Relicis Medical Devices for groundbreaking medical solutions. He's also the president of Inaugural, the Health Systems Institute, and is committed to advancing quality healthcare globally. May I also take a minute to introduce our very, very distinguished guest and keynote speaker, Dr. Sohel Saikat. Senior Advisor and Lead Health Systems Resilience and EPHFs, UHL WHO, Geneva. Dr. Saikat, currently serving as the Senior Advisor and Lead for Health Systems Resilience and Essential Public Health Functions at the WHO, boasts of 20 years of experience in integrated health systems, strengthening for achieving universal health coverage and health security. As the WHO's Senior Advisor for Public Health Care, he played a pivotal role in national planning for health security, contributed to the joint external evaluations, and led efforts in humanitarian response, recovery for nations facing protracted emergencies. I already have the privilege of saying that we will take up of his idea of making sure that we have a health systems journal that will come out before the end of this year. Thank you, and grateful to you for joining us. Now I set the stage for Dr. Reddy to take on and set the context. Thank you.
Thanks so much. At the outset, I would like to welcome all of you. I would say the keen learning audience. All of us are learners in this venture. The very objective of establishing this Global Learning Collaborative was to contribute to the efforts of making health systems strong, secure, and resilient. And this objective is through the collaborative virtuous cycle of learning to action and action to learning. The whole idea is to build that culture across health systems without looking at whether it is yielding an impact or not, because any learning ultimately has to lead to impact. So that is the founding objective of this Global Learning Collaborative. The last year we outlined the guiding principles of this learning collaborative, that it has to evolve in a self-organizing way. It has to be self-governing, and it has to be self-sustaining. The seed funding came from the Rockefeller Foundation. However, as envisaged as a part of this guiding principle, that this has to be self-sustaining. It is driven by the founding purpose, not by a single donor, not by a single agenda, but the shared purpose. So until it becomes self-sustainable, we have committed to nurture it so that it evolves into an entity that results in the founding objective of building strong, secure, and resilient health systems. The journey in the last 2 years, since its beginning, 2 years is a small period in institution building. However, it's gratifying that this collaborative effort has moved significantly in its journey of trying to learn from the mistakes that we committed during the COVID. In our short memory of already the systems of gating that we went through COVID, before we forget that, this journey of learning keeps us reminding that it should not be a one-time effort. It should be a continuing culture of learning on a day-to-day basis, not just on a yearly basis, that what we are learning from the mistakes and what we are learning from the positive things that we are doing. As a part of that, the collaborative explored the very definition of what is the resilience, what do we understand by resilience, how do we differentiate between the various words we use in terms of health system strengthening, health security, universal health coverage. So these are some of the words that the system has to clearly understand what exactly we mean by resilience, what do we mean by security, so that there is no confusion in translating some of these terminologies into actual policies and actions. The second was an attempt to reimagine the model of health systems, building upon the 6 building block model of the WHO. It was outlined in the last annual conclave that we look at the people as the center of this health system, the people's health, their health needs, that dictates actually the evolution and the transformation of the health system. And those response of the health system through the core functions of provisioning, the supplying of the goods, the financing on the supply side as well as on the demand side, and most importantly, it's mentioned but not elucidated, the governance function. Not the government role, but the governance function. I think these are the 4 core functions, plus the model envisaged the 3 more equally important integrative functions, the cross-cutting functions, which are not given the importance that they require because they enable the integration of these fragmented and the complex health and the social systems. These are how the information is flowing across the system. Is the communication happening in terms of the public health communication? And how the relations are actually institutionalized. The relations, the international relations, the center-state relations, interministerial relations, the public-private relations. These are the complex actors at different levels. So these are the central people, the 4 core functions, and 3 cross-cutting functions. In the background of the emerging consensus concept that people's health does not exist separately from the plant health, animal health, and the planet health, so that means integrating the One Health concept. So the schematic depiction of this conceptual understanding was presented last year. And the learning journey is actually carried along these 8 thematic areas. And as the learning journey takes place, each thematic area is diversifying into multiple subthematics. Last year, I quoted the example of the river looking to join the ocean. The ocean is the purpose. The river is the journey of learning. And it branches out, irrigates the fields, and then rejoins to form the river so that it relentlessly progresses to the ocean. So the GLC journey will be like that. That means the knowledge and the learning has to branch out and reunite in these annual meetings where we bring back whatever happened in the last 1 year into these fora, and through the dialogue, again, bring out some new ideas and the new topics and the new priorities so that the next 12 months, the journey can be continued by the members, the partners who are organizing around these thematic areas. Some of these thematic progress, I think, will be discussed in the subsequent sessions. As you might have noticed, these 8 sessions are organized around some of these 8 thematic areas. In addition, they also explore some of the new threats that underlie the resilience concept in addition to the pandemics. Not only the pandemics, but also the geopolitical conflicts, but also the climate change. And more importantly, it's not just a dramatic public health emergency, but the slowly building crisis in terms of the non-communicable diseases, in terms of antimicrobial resistance. I mean, these are the things which these next 2 days, I hope we'll have interesting dialogue and the discussion, which should lead to at least a summary of insights which can be taken forward, either as an action, as a policy, or as a strategy, or as a pilot, which is already happening in terms of various thematic areas. Before I conclude, just the first thematic area which we felt, the GLC felt, was the most important is whatever policy or strategy or the planning begins with, are you assessing the health system correctly? Do you have the competency and the capacity to assess? I mean, just like as a clinician, our core competency is to assess the patient's problem. The clinical assessment is the starting point. From a health systems leadership perspective, the health system think tank's perspective, do we have the clarity of assessing the health system, assessing the people's health, assessing the determinants of people's health, understanding and assessing the people's health needs? And during this learning process, one more thing that came out, there is a huge gap between what we perceive as a need and what actually the people seek. Then we are not addressing that gap, the factors behind this need to demand and the demand to supply. So these are some of the emerging thought process as a part of this learning process. And I'm sure, I think the next 2 days, at least I have been learning a lot. I mean, being new to these health systems and the public health. I'm a cardiologist, I'm a clinician. But at least I enjoy these learning sessions, and I'm sure all of you will enjoy, because idea is to have a joy of learning these next 2 days and not press for the time. That's why we have tea breaks and lunch breaks in between the sessions, so that you can spill over in case if the topic is very interesting, so that the moderator does not close your topic. So I don't want to extend my time. With these few remarks, I welcome again and wish you a good learning in the next 2 days. Thank you.
Thank you, Chair, and thank you, Dr. Reddy. I think the work you are leading, I think, is very, very close to WHO and is also very central to avoid the phrase panic and neglect. I think we just came out from COVID-19. Before that, we had Ebola in West Africa. Before that, we had H1N1. And also moderator mentioned about the Spanish flu. So if you have to change, I think it has to have an intentional effort, a conviction for change. So the work you are doing, I think, is very, very close to WHO, is very, very close to every member states of the United Nations. And I also like to thank the Rockefeller Foundation for supporting your mission on this topic. So colleagues, this is the reality that we have in health sector. COVID masked many of the problems that we have on a routine basis, from aging problem to NCD, the impact of climate change, rapid urbanizations. So all of this has a either direct and indirect effect on health systems functions and health systems services. But they also remind us how, I think Dr. Reddy mentioned, how health is also interconnected with wider sector in every country. So the central question here, we cannot accommodate parallel system to address all of these issues in a siloed manner. We cannot have a health systems only to focus on NCD. We cannot have a health systems only to focus on climate change, which is economically unaffordable, while we embrace and institutionalize health in all policies, we need to find a way for health systems to be more self-reliant so that we can tackle a small emergencies before it could become a big emergencies. How can we diversify our service delivery platform to provide routine health services? At the same time, those are unanticipated. For example, we did not anticipate COVID-19. So the resilience aspect is very, very core to tackle all of these diverse challenges. So colleagues, this is another reality, a global reality. There are 4 figures. I think the one on the top is related to financial protection to access quality health services. So that figure, I think you can also kindly look at in the slides if it is not properly visible from the screen. So it reminds us that the financial protection is not just a problem of the low-income countries, it's a problem in all countries. So it's related to COVID-19, which further confounded the issues, but there are pre-existing financial protection issue even in high-income groups, as well as supply chain aspect. And then if you look at the one on the right-hand side, that big global representation, this is about geographical barrier to come to a health facility to have the services. So the darker the color, that means is more difficult for the communities to come to a proper healthcare facilities. So around 43% of the global population needed to walk more than 1 day to come to a nearest health facility. Around 8% of the global population, even if they take a motorized transport, they need more than 1 hour. And then if you look at the one on the second row, on the left-hand side, I think that is the countries who are affected by fragility and conflict. I think we do not need to say much about it. I think 25% of the global population are affected by conflict, very fragile health systems to maintain essential health services. That's not only impact the people who are displaced, that also impact on the local population. And then one on the right-hand side is the one that WHO conducted during the course of COVID-19, the impact of COVID-19 on maintenance of essential health services. And that is not based on a sound methodological approach, because health systems, health information system collapsed in every countries, whether it is in Pacific to North America to Russia to Sub-Saharan Africa. It was indiscriminate. WHO did not have any data about how many people are dying due to lack of services, because the health information system in every country was compromised because of the impact of COVID-19. So there are some extraordinary statistics. 92% of the countries reported service disruption. So this is an unacceptable situation that we had during 19. But the major aspect here is that you cannot expect international health regulation implementation. You cannot expect global health security if 5%, for example, of your population are outside of public health services. So that means your surveillance, laboratory diagnostics, contact tracings are going to be flawed, given that 5% population who remain outside of your health services can allow transmission to grow, mutation to grow. So that means if we think that 95% of implementation of IHR or pandemic preparedness is not going to provide that type of protection, type of economic security related to health that we want. So colleagues, the reality is here. The reality, I think Dr. Reddy, I think at least 10, 12 times he mentioned about integration. So this is another, completely from a WHO, a global perspective. I am not picking a country example here, but if you look at the way we all operate from global to country level, is very, very siloed. I think even including the donors and partners, we support, for example, the implementation of International Health Regulations 2005. And then in the same country, there are health systems strengthening, focusing on 6 building blocks. At the same time, there are many countries have also vertical disease-specific program, polio to NCD to climate change. And then if that country happen to enter into a humanitarian crisis, there is also humanitarian response planning. And all of them has got separate budgeting, separate monitoring system. So there is a missed opportunity to bridge between all of these big investment efforts to proliferate benefits in baseline health systems capacity development. But this situation is unfortunately unaffordable one, given the economic contraction that we are experiencing in every country. Secondly, we are missing the legacy of all of this investment. So this has to be changed. I think this is another, I think we all know from a perception-wise, Europe in general champion on public health. So this is the data from European Commission of all of its member states. So what I wanted to convey from here is that if you look at the budgetary distribution in terms of GDP, so hospital account for 3.4%, and then outpatient within hospital is around 2.5%, and the public health is only 0.9% of the GDP. And then we looked at what this 9.9% consists of. So 0.9% is only about health protection aspect. Within the health protection aspect is cherry picking only some aspects of public health, mainly on epidemiological capacity. So the aspects of health promotion, health prevention, and wider aspects of health protection has been largely compromised, overlooked. But as we have seen during COVID-19, this type of health systems development, focusing on clinical care, focusing on secondary and tertiary care, cannot protect any country. It did not protect Europe. It did not protect countries in North America. It did not protect countries in Western Pacific. Because healthier the population goes into a pandemic, healthier the population will come out from that pandemic. So we need to look at these things in an integrated way. So we as a team from WHO headquarters, I think we have started this work post-Ebola in West Africa with a dedicated focus on health systems resilience. I think the concept is out there, is in defense, is in fire service, is in psychological aspect, is there. But in health, I think it was came out as strongly, but the operationalization aspect has been absent. So this is the definition that we as a WHO came up with, a practical one, what it is. I think is my two co-moderator and Dr. Reddy, I think, mentioned about the awareness knowledge harvesting. And this is not a rocket science. If you want to understand, this concept is not a difficult one. It's the ability of the system, whether the system as a whole, infrastructure, communities, facilities, everything, whether they have the capacity to preempt the risk, to prepare to tackle the risk, minimize the risk, and if this happens, how it can effectively respond, and not just response, how it can also translate the lessons learned into some real practice. So in terms of function, I put something there, is to maintain the services. If there is no services from the health system, that is the key. Whether if you have got a cough, you need to go there in the primary care facilities. If you got something more nasty, we still need to go there. So the services need to be there in every context. Second one, if there is an unusual event like CVRN, terrorist activities, cyclone, you all also need to go there to have that type of specialized care. And third aspect is a better integration between public health and healthcare service delivery. And then the fourth important one, how we are translating the lessons learned. I think we are the intellectual global communities, how we can translate the everyday lessons learned. On the right-hand side, I put WHO's health systems building blocks, governance, finance, supply chain, information system, service delivery, etc. But what I wanted to convey here is that we cannot expect that resilience will be automatically happening unless we closely scrutinize each of the health systems component building blocks and how we can intentionally act on it. And then the other most important one is, you know that within WHO, this focus on primary care. Yeah. Sorry, I just taking a bit of a time. Yeah. So colleagues, I think you all part of it. I consulted with Maulik and his teams on some of the work we have been doing from headquarters. So to demystify this resilience, we as a headquarters WHO team trying to come up with a complete tool of technical product and package that you all can also look at. You can work with them to contextualize in country support. So from policy planning to implementation up to monitoring, evaluation, and learning. Most of these products are now in public domain. When I say product from WHO, we try to make sure that they are of global standard. We are not the perfect, but we'll try to achieve the maximum standard that we want to have. So, colleagues, like you all, as I mentioned, we as a WHO, we also have a work to do. We are also fragmented in the way we operate. So with COVID-19 experience, we also wanted our house more closely together between health emergencies, health systems for universal health coverage, as well as health promotion. So for the first time in the WHO's history, we brought all programs together and came up with these 7 policy recommendations. One, for example, how can you leverage resources that has been mobilized during COVID-19 can be transitioned into recovery and longer-term health systems are strengthening. How can we extend the primary care with public health functions? How can we institutionalize this whole of government, whole of society approach? How can we further enhance the knowledge agenda? How can we build the health systems foundations in countries in fragility, in conflict, and violence affected? So this is just a few slides, colleagues, about the technical package that we have been developing. One is the Health Systems Resilience Toolkit. Is the first time that we exhausted what is out there globally. It's not not all WHO's document. What is the current state of global knowledge and practice on health systems resilience? So this one document can serve as a compendium of the repository of all global knowledge piece, and we organize them into 4 modules, from policy up to monitoring and evaluation. And then any country can look at it, and is a live document, and then they can pull the right materials and then can address whether it can fit their purpose. This piece, just before I came from Geneva, I looked at it, is going through now executive clearance. So when we did that global review, we identified that there is a still lack of clear practical guidance how to operationalize resilience in health and allied sector. So based on this extensive work, we as a WHO call is a technical product or global public health goods, we came up with 5 steps to operationalize resilience, from policy planning up to the service delivery platform. And it's not that difficult, but it needs proper political commitment. It needs how can we change current health sector planning. Not a difficult change. These are all doable change, but we need that solidarity, that shared commitment to change the way we currently invest in health sector. So this document is soon going to be out in public domain. And colleagues, again, it was very, very intentional that I led this process with our Deputy Director General during that time, Dr. Susanna Jacob, and the President of IANF International Association of National Public Health Institutes. We put the questions to the global domain. How many countries are considering recovery from COVID-19 and protracted conflict? If no countries consider recovery from COVID-19, that means we are again embracing panic and neglect. We are not translating the lessons that we learned from COVID-19. We are not finding a way to transition additional resources that have been mobilized during COVID-19. For example, you know that every country either printed money, borrowed money, bought new ambulance, built new healthcare facilities, additional beds. So there is so much of attention in the health sector. But the issue is that if none of those assets that have been mobilized during COVID-19 could remain or transition into health sector with a proper operational planning, we cannot expect that all of those resources will be there for next pandemic. So the choice of the title, it was, I said that let's challenge the global communities. So this is a body of the work that was published last year by closely working with a journal led by WHO. And again, I kindly request you to use it as a reference. This is another piece, is to support how countries can apply integrated approach in planning. And this product is also going to be out in a couple of weeks. So this one is very close to the discussion that you are having. It was published just, I think, last week or week before. For the first time, a complete compendium on indicators to measure resilience in health sector, underpinning public health approach as well as primary care. And it talks about the integration aspect with a simple handbook. And we as a WHO, we cannot expect that everything will change. So you can all apply by looking at your current health information system, DHIS2 or IDSR, and see what types of indicator that we as a WHO developed can fit into your context. So this is in public domain, and I believe this is also one of the reference you are going to use in today and tomorrow. So colleagues, just very briefly on some of the country applications post-COVID-19. So there are, as I mentioned, the problem that we had seen during COVID-19 is not necessarily only the problem that we have seen countries with a low resource setting, countries with a fragile health system. So there are 3 countries that we as a headquarters are supporting directly in different countries. One, Germany, Azerbaijan, and Ireland. All 3 of them are really reflecting on lessons learned from COVID-19, how they can embrace more integrative, more comprehensive public health in the way they have been operating. For example, in Germany, I believe you all know that they have got a very famous public health institute called RKI, Robert Koch Institute. So they are now planning to complementing RKI to have a federal institute for population health so that there can be proportionate focus on promotion and prevention aspect. In Ireland, they are coming up with, for the first time, comprehensive public health strategy, and they commissioning us to guide the national process. In Azerbaijan, they are also looking at the current public health workforce capacity and building the institutions to guide integrated approach to public health. So colleagues, this is a project that we had funded by COICA for the last 5 years, and in Ethiopia and Liberia. And this is a complex picture, but I will just simplify it. So normally, we all work in a country either in public health side or in the hospital sector in terms of clinical care or just a veterinary sector. But here, if you look at on the right-hand side picture, we looked at the referral system by applying catchment approach and identified from referral hospital up to the lowest level of healthcare service delivery. At the same time, we also mapped public health institutional aspect as well as the service delivery along with the veterinary sector. And then by developing that catchment mapping for healthcare service delivery with public health and veterinary sector, we applied the same principles of support based on 10 action areas. The reason is that if we cannot build the capacity at the primary care level, we cannot expect the capacity that we developed in hospital can be sustained. So based on the infrastructure, we tried to develop a sector-wide development for building resilience in Ethiopia and Liberia. So this is another one, colleagues. South Sudan, the newest UN member states, very, very fragile, oil-rich, but as soon as it got independence, it has been affected by internal conflict. So we had the opportunity to work with that type of difficult context countries. What we had done, we systematically looked at the gaps, critical problems in health systems, building blocks, And we also looked at the cross-systems issues, how different building blocks can work together, how can we empower Ministry of Health to take responsibility to provide the transitions. And so this work is one of the example setting to systematically support countries into recovery and long-term stabilization process. So this is my last slide, colleagues. So we all can relate us in the first shock as a COVID-19. And we have seen that disruption in service delivery. We have seen disruptions in the social stability, economic aspect. So unless we can build the capacities in line with resilience, we cannot expect a different result. But if we all work hard with our member states, Ministry of Health, NGOs as civil society actors, and build the resilience in the health sector so that if there is a next pandemic, we can expect that the disruption in terms of service delivery, disruption in terms of economic impact can be more manageable. So this is what I would like us to see, that during COVID-19, you know that around 7 million people died. Around 14 to 17 million people died due to lack of services. It was a modeling data because we did not have the sound data to calculate excess mortality. And you all know the economic impact. It was billions. So God forbid, if there is a future pandemic in 10 years' time or 100 years' time, how we are going to judge ourselves? Should we judge with the first one, with the similar level of impact, or should we expect to have a better management system within health sector as well as in allied sector? So this is the last picture that I want to send. They're all underpinning the concept of resilience. Thank you very much.
How does one wrap up and talk about such a brilliant presentation that gave us such a broad brush for what we need to speak for the next 2 days? I'll just make a few points from service disruption that actually came as something as important as everything came to a standstill 4 years ago. Integration, that's the spine of where we would like to go. Economic securities and insecurities that need to be how we are going to view and how are we going to take the next break when that happens. I don't want to call it a pandemic. How do we look at all the missed opportunities that we've had? And how do we make sure that we utilize those before the next shock happens? Awareness, literacy, the premeditative nature of what we need to do, outreach that we need to make, tackle and minimize how our shocks can be, and respond to those and those lessons learned that we need to make sure that we predict and prevent rather than work in retrospect. Securities, building the blocks, intentionality, acting upon it. Health systems toolkits, the WHO was there and is there to help us go through this. We will make sure that we deliberate over the next 2 days, from shock to knowledge to action. And we're grateful for your presence here this morning. Thank you so much. That was such an insightful talk. Shall we open it up for questions?
Okay.
Yes.
At the beginning of your talk, you said that we did not anticipate COVID-19. I suppose that's a true statement on its surface, but I think it's misleading. There were many reports on pandemic threats. They focused on influenza, but the preparedness that if we had taken those reports seriously, and those reports came from WHO, came from US CDC, came from US NIH, came from the European community, all over the world. I remember the pandemic preparedness report of the US CDC was revised in 2017. And what did they say? They say that it is inevitable that we will have a pandemic, likely from an emerging influenza virus, and that we're going to need treatments. We're going to need personal protective equipment. We're going to need extra beds. We're going to need masks. We're going to need ventilators. All of those points were in those reports. And the world did nothing. In fact, in the US, where I work, we started to do something. We had major contracts to build ventilators and major contracts to expand face covering production. But we stopped them short of actual deployment. In other words, we developed the systems to do low-cost, high-volume ventilators production and high-volume mask production, but then we didn't make the masks, we didn't make the ventilators. So I think it's misleading to say that we didn't anticipate this. It was anticipated for years. There's a huge literature on the burgeoning risk of a global respiratory pandemic. So when COVID hit, those of us who do this for a living were not surprised at all. The only surprise was that it was coronavirus and not another virus. So I just wanted to make that comment and see what you thought.
I think it was a more generalized statement that I think if you think of risk registrar in every country, the respiratory disease virus, they are always in every country, whether you think of US or you think of even countries in low-income setting, is always there. So what I'm saying is that even if you prepare for a respiratory influenza virus, there are so many other novel pathogens as well as zoonotic disease that we are not anticipating, but the risks are still there. So what should be the way we can prioritize our health systems resource? So the way to prioritize our health systems resource is how can we develop baseline capacities. I think you mentioned about pre-stocking PPE, etc. They should be part of contingency planning for every countries, but with a global solidarity and cooperation. We cannot expect BSL-3 or BSL-4 labs in every countries. So there is a global dimension, but at the same time, how every country, I think the resource is going to remain tight. How can they think of a scale efficiency in a way that baseline capacity are there? If there is a transmission at the community level, if you recall how Ebola started in West Africa, somewhere remote part, they are completely outside of normal healthcare service delivery. So this is the relationship between universal health coverage and the health security. So we need to find a way to reach the people who are outside of the health services. At the same time, how can we come up with a rapid way to mobilize the resource, rapid way to mount the response so that it can be tackled at the local level? Otherwise, we can build, I was in China in December. So in the Chinese model of health systems development, I think it was very much focused on a lot of investment on tertiary care, more and more bigger hospital. But now there is a reflection that type of investment in a country like China is an unaffordable one. So they are talking about bundling comprehensive public health services at primary care level so that there can be fast detection, fast diagnostic, fast contact tracing. Otherwise, people will all go to the hospital will get inundated, will go beyond its capacity. So totally agree with you. All of these risks are there, but the issue is that what types of preparedness that we want in every country and global domain. Thank you.
Thank you, Dr. Saikat, and we'll have to bring this. Can we take? I will need to ask you to have this question later. Yeah. Thank you so much. Appreciate Dr. Reddy and Dr. Saikat.